Good afternoon, everyone, or good morning, depending on where you're joining us from. My name is Ifta Amit, and I'm one of the board members of the Hospital in the Home Society Australasia. I would like to begin by acknowledging the traditional owners of the land on which we meet online today. Each one of us, from our own respective place that we're joining from, may it be from the workplace or from home. For me, that's the land of the Wurundjeri people of the Kulin Nation, and I pay my respects to the elders past and present, and extended respect to any First Nation people with us today. We are pleased to announce that we actually now have our fantastic conference. So it is going to be the 17th annual scientific meeting of the HITH Society, and the registration is officially open. We do look forward to seeing you all in person on the Sunshine Coast. As you can see, the QR for registration is just there at the bottom, and will take you to the conference website. So for today, we are going to talk about the grand round of measuring what matters, patient experience and complexities in HITH. In this session, we'll explore two innovative approaches to better understand the HITH patient journey, from how patients experience care at home, or how we assess and manage clinical complexities in this unique setting. We're joined by two outstanding speakers. Associate Professor Penelope Bryant, who will share findings from validating a purposely built tool for measuring patient experience in HITH programs, and Dr. Sarah Jame, who will present a practical framework for complexity scoring in HITH patients, including its application in clinical decision-making, resourcing, and benchmarking. As always, we are inviting you to share your thoughts, questions, and reflection in the chat throughout the session. I would like to thank our speakers, everyone behind the scene who helped make today happen, and all of you for joining us. And of course, thank you for our HITH Society members. Your support allows us to continue hosting these important events. If you're not a member yet, we encourage you to consider joining us, growing community. It's a great way to stay connected and support innovation in hospital and home, like these grand rounds. Joining is easy and can be done using the QR code on the screen or the one behind me. It also provides you with a discount rate to attend our conference. Lastly, a reminder that the views expressed today are those of our speakers and do not necessarily reflect the position of the HITH Society Australasia. Any opinions I share today, of course, are my own. So let's get started. Over to you, Penelope.
Thank you, Iftar. And I'd also like to say that any bad jokes are only mine as well, and not anything related to Iftar or anybody in the HITH Society. So I'm just trying to minimize the thing on the side because it's going to go over some of my talking, but let's start. So thank you very much for attending, and thank you for inviting me to the Iftar and the HITH Society. This is a piece of work that has been done really over the last year about trying to find a way to validate our patient experience measures in hospital and the home programs. And we've called it the Hospital at Home Questionnaire because that's obviously one of the phrases that is more commonly used around the world for hospital in the home. But by calling it the HHQ, it's hospital at home, hospital in the home, home hospital. As long as it's got the words hospital and home in it, then it works. And I'm doing this on behalf of myself and Dr. Elise Horstman, who I think is online, who was the person who did all of the hard work for this. And then I've receiving all the glory. That she was our Hospital in the Home Fellow last year, and was really instrumental in making sure that the actual nuts and bolts of this happened. So for some reason I can't move forward. Let's try that. There we go. So this was presented quite recently at the World Hospital at Home Conference in Vienna, and a number of us flew over to Vienna to attend that conference from Australia. This is the lovely photo that was taken of the Hospital in the Home members from Australia who were there, but not everybody could be in the photo. So by the powers of Photoshop, I bring you all of the other people who were also present at the conference. So just to start with, I thought I'd start with what we actually mean by validation. Now, there's all sorts of different types of validation. There is social media validation. There is parking validation. And to all the parents out there is very big, important feelings validation. However, what we're really talking about is what is really epitomized by this video that was a very well-known advertisement in England in the 1990s.
This is Ronseal Quick Drying Wood Stain. It's a wood stain from Ronseal that's quick drying. It protects your wood and is rainproof in about 30 minutes, which means in about 30 minutes you'll be rainproof and protected. So if you want your wood stain to dry quickly, use Ronseal Quick Drying Wood Stain. That's exactly what it says on the tin.
And that's really what we're talking about with this survey, is we want a survey that does exactly what it says on the tin, because we want it to actually validate patient experiences in hospital in the home, but we also want it to be specific to hospital in the home. And that's really what we found when we had a look, is that there are lots of experience measures for clinical care for patients. And a literature review will show all of these, and we had a good look at these, but the vast majority of them are specific to hospital experience. And when you look at the questionnaires, which a lot of these are based on, again, they're almost all either about inpatients or hospitals. And even the fourth one down there, the patient experience questionnaire, is about healthcare services in general and doesn't have anything specific about hospital level care in the home. So what this told, and what matters most to patients, as we can see, really one of the most important things that patients are interested in is getting home. So what this told us was that there is a gap in the market. So how do you validate a questionnaire? So this is something that Elise and I had to learn from the ground up. And even when we spoke to our very experienced statistics team at the Murdoch Children's Research Institute, they really said, well, just have a go and see what you come up with and then come back to us. So, so Elise and I had a go. So we start off with content validity. So what content validity means is looking at what's already out there. So doing a literature review and getting some patient feedback, and then asking expert clinicians in the area. So here we go. We started with content validity, and we did the literature review, and I showed you some of those results on the slide a couple of slides ago. And it really showed us that the vast majority of what was out there for patients and measuring patient experience was for hospitals. We also, in the 6 months prior to starting this piece of work, as we always, and I think most of us do this, we always send out a survey to all of our patients after they finish their hospital in the home episode of care, asking them about their experience. And in the 6 months prior to doing this, we added a question, which was, what do you think that we should be asking you in a questionnaire about your experiences? Because we really wanted to hear first and foremost from patients. And using the literature review and the responses from those questions, we drafted an initial hospital and home questionnaire survey. And then what we did was we sent it around the expert group of clinicians, so that involved doctors and nurses and allied health members, many of whom are on the online today, to say, this is what we and the patients have come up with, but everybody works in different services. What does everybody else think? And so we had feedback, and we did a modified Delphi process of sending it around iteratively, and does everybody now agree? And some questions were taken out at that point, some new questions were added in, and then we came up with, at the end of that, a survey that really covered 6 broad areas of hospital and the home. So communication before coming to HITH, communication during the HITH admission, care coordination, accessing care, confidence in care, and then overall satisfaction. So having done the content validity, the next, and to my mind, the most important stage is the face validity. So this really involves pilot testing and feedback. So what you do with face validity is then to send it out to a small group of the patients that you're wanting to measure their experiences of. And so we sent it out to 10 families who had recently had their child have an episode of HITH care, and ask them what they thought of the survey that we had put together from other patients and from the expert clinical group. And they were all unanimously supportive that this needed to be done, but also generally supportive that this was a good survey from their point of view. So it didn't take too long, it was easy to understand, and nobody felt that there were any additional questions or questions that needed to be taken away. And that was part of the initial the survey. At the end of the survey, we asked those questions. There was also some constructive comments. It was felt that it could be more inclusive in its language, and particularly in the welcome to the questionnaire at the beginning, to be more inclusive of a wider demographic, and specifically and proactively inclusive, to say we particularly like to welcome and encourage people from Indigenous backgrounds, people who English isn't their first language, from LGBTQI+ backgrounds, so that it was more inclusive and people were visible, because often those demographics may feel less able to respond to generic surveys, or that it's less relevant to them. It was also felt that we could use even simpler language than we were using. So for example, we would use things like, to what extent did you experience? And instead they said, you can just say, did you experience? Even if you put a Likert scale on it, you can still make it simpler. So we made those changes, and then at the end of that, felt that we had achieved base validity. So the next stage in validating a questionnaire is construct validity. And this involves a couple of analysis types, for which Elise is now an expert, and I'll explain what these are as we go through. So first of all, in construct validity, you then need to test it on loads of patients. And we asked our statistician, and we said, how many? And she said, how long is a piece of string? So we decided how long a piece of string was, and we thought at least 100 patients and families we needed to ask. And when we asked Susan, our statistician, she said that sounds about right. So the survey was then shared by clinicians while patients were on HITH, using a QR code that was on the back of the SpectraLink phones that the home visiting nurses and allied health teams use. And then we also sent the questionnaire weekly out by SMS to all patients. So our admin team did that, who had been discharged from HITH in the previous week. So they had the opportunity to complete the survey either while they were on HITH or immediately after finishing HITH. And we ended up having it completed by 134 patients before we stopped enrolment in this part of the survey validation, 126 parents and 12 adolescents. And of those, 4% were Indigenous, which is slightly higher than our Indigenous rate in our hospital and home programme, which is about 2%. English, not the first language, 11%, and our rate is about 15%. And children under the age of 1, and that's about representative. And so in analysing construct validity, we first of all looked at the overarching domains. And so what you can see here is the 5 domains that I mentioned on the previous slide. And overall, when you analyse those data, you can see that if you look at the results, and the results are the mean for each group is the dot, and then the standard deviation is the bar, and the parent results are in the dark blue, and the adolescent results are in the light blue. And what you can see is that in general, there was very high satisfaction with HITH, although adolescents, being adolescents, had a broader range of views than their parents. But then what we're also interested in is looking at the specific questions. And so, for example, I'll just pick 2 examples here. Domain 2, communication on HITH. And as you can see, again, high levels of satisfaction, although wider standard deviation with adolescents. And what you can see there, and what we learned while we were doing this validation, was that you need to ask the questions in the same way. So the first 3 questions there are all asked in the same ways. Were you comfortable with your experience on HITH? Whereas the last question is really asking, how does HITH compare to hospital? And both of those are completely legitimate and important questions, but they're actually asking it in a slightly different way. Likewise, confidence in HITH care as an alternative to hospital. So the first 4 questions there, we asked, were you confident as an alternative to hospital regarding medical needs, comfort, hygiene, emotional support, and high levels of satisfaction. But then the last question is again asked in a slightly different way. We're asking more about comparing between hospital and the home, rather than just asking if they're happy with it as an alternative. And this is important because when you ask questions in a slightly different way, you end up with different results and questions that maybe don't hang together quite as well within the domain. So construct validity is asking, do the questions in the domains hang together? And to do this, you do an exploratory factor analysis, which is how many domains does the survey itself, not to anthropomorphize it, but the survey itself think it should have based on the patient answers. And what the survey said was 5. And so that was 1 less than the number that we had initially designed it as. And what we realized was that we were asking questions that were relatively similar in care coordination and communication during HITH admission. And that actually what we could do was pull those 2 together and remove a couple of questions. So we ended up with 5 domains by pulling those 2 domains together. So then if you look at the construct validity of those 5 domains, what you're looking at is the correlation, which ideally should be above 7, but it's completely still valid to be above 0.6 if all of the others are higher. And as you can see, slightly lower correlation within the domain for communication on HITH. But the key is that all the p-values should be significant. And as you can see here, they were all highly significant. So the construct validity was then passed, and then the next stage is probably what most of us more consider understanding of validation of anything, is the reliability analysis. And this involves internal consistency and then test-retest assessment. So as far as internal consistency goes, this is analysed by something called the Cronbach's alpha, which I kept thinking was called the Kronsky sausage. I think Elise had a different name for it, but that's not its name. Its name is the Cronbach alpha. And here you really want it to be as high as possible. And as you can see, these were all very high. And what this really means is that all the questions relate to all the other questions, and they're all asking the thing that you think that they're asking. You can see that it's slightly lower for accessing care on HITH, but when we look back at the questions on accessing care on HITH, they're really quite different. So although we consider it clinically as accessing care on HITH, the way that patients might experience it might be a little bit different. So for example, one of the questions is, were you able to access medication while you're on HITH? And one of the questions was, did the visiting clinician always attend in the time that they said they would attend? And those are quite different things with really quite different constructs. So even the fact that the Cronbach alpha was over 0.6 was reassuring. And then finally, the test-retest reliability. And so traditionally with a questionnaire, what you do is you do a test on the same patients and then the same patients down the track. Because this questionnaire is anonymous, we needed to have new patients. So after closing the first set of patients, we then took 35 new patients and we matched them for the age of their child and the intervention their child was receiving. And where possible, we also matched it for English as a first language or not. The demographics were relatively similar, so it's few more patients proportionally who were Indigenous, more patients who English was not their first language, and similar number whose child was under the age of 1. And if anything, we really wanted to make sure that we had more patients in demographics who might not traditionally answer rather than fewer. So again, that was reassuring. And what we found on the test-retest reliability was that the intra-class correlation was 0.9, which is very high, and that the difference between the two tests at the 2 different time points was 0.5, so no significant difference between the tests. So in summary, it's valid, hooray! Yeah, I'd be very happy to end the presentation there, but of course, it doesn't end there. So it's all very well to give each other a nice pat on the back. And this isn't actually a picture of anyone patting Elise on the back, but it's a picture I took from Google of people patting each other on the back. This is a picture of Elise and myself standing with very funny hand gestures in front of the poster at the HITH conference in 2024. And this poster was just like the first 2 stages, the content and face validity, and then the rest I've just presented to you. And I realized that the reason we're doing these silly hand gestures is that Elise was awarded the best poster prize for anyone who wasn't there for this poster. And then finally, the aim is to get it published. And when I presented this in Vienna, somebody asked me afterwards, wow, have you got this published in the New England Journal of Medicine? I'm like, no, of course, I haven't got it published in the New England Journal of Medicine. But obviously, we're aiming for a high impact journal, because I think this is a useful piece of work. But really, where it all comes back to is patients. And so the point of validating a survey is so that you can collect patient experience data, analyze that data, and then plan for improvement strategies, implement the improvement strategies using this data-driven approach, and then loop back and collect the patient experience data. So to that end, what was the patient experience? So I've presented some of the quantitative data, which I think is valuable, but I think also when you're really trying to make improvements, it's nice to see the patients in general are satisfied. But what you really want to do is pick out some qualitative data as well. And in the HHQ, there are some qualitative questions as well. So there were a lot of positive qualitative responses, that the support and care was incredible, that it had given the family the opportunity to have a more normal life during their child's illness, and that they found the care excellent, holistic and empathic. But it's also important to look at the negative qualitative responses. And so some of these were that there was no consistency with nurses coming to the home. And that's, for potentially understandable reasons, but also, are we trying hard enough to make sure that the same nurses, if they can, with all else being equal with the scheduling, visit the same patient? And that's good for both the nurse and the patient. It's more straightforward for a nurse to see the same patient because they don't need to take the history from scratch each time. But also it's important for both the nurse and also allied health teams to be developing a relationship, and important for the child and family to be developing a relationship and confidence in care with the staff. Some families found that the timing of visits was hard to navigate, and as a number of you know, we're doing separate piece of work looking at automating and communicating with families better and having shorter time windows. And then something which I thought was really important and came up a couple of times was sometimes we would get conflicting advice from the team. And for one family, the conflicting advice was conflicting advice between the HITH team and the inpatient teams. And in some, when you delve into that a little bit, sometimes that's because sometimes it has to be different because you're in a home context rather than a hospital context. But actually, and what appears to be conflicting for the family is not. And so that's really around communication from us around what's different, but also conflicting advice between different members of the team. And that's really important because we have different ways as clinicians of presenting things, but actually we should all be saying things that are clearly understandable to the patient, that we're all giving the same care in the same, even if we're not saying it in the same way. So again, that's something for us to take back at the Children's Hospital of how can we improve that. So I put this picture in because the large majority of people who were involved in this were the paediatric HITH folk, and this is a picture of us all at the HITH conference, HITH Society conference last year, and I just thought it's a nice picture. But the take-home messages from this are that the HHQ is now the first validated tool for assessing patient experiences on HITH. And with having both quantitative and qualitative responses, they're both valuable in improving patient care. But the key to having a validated tool is not just that we can say that it's actually measuring what we think it's measuring, but also we can use it to benchmark across services, because everybody's asking the question in exactly the same way. It then is more clear what the differences might be, but also more clear what the similarities might be. So the aim is that once this is published, this will be an open resource. So lots of questionnaires you have to pay for. The idea is not that this will be something to pay for, partly because I'm obviously a socialist and I was brought up in the NHS, but also partly because I think that it is important. If you really want people to use things, really want parents to use things, you need to make it not cost friendly for everybody, both clinicians and parents. The other important thing to say is that what we've done so far is we've really validated it on parents and adolescents, and we've asked actually on some more adolescents now, and we're going to further validate this with more numbers through the Paediatric HITH Improvement and Research Network, FERN, which we're about to do a study on. We're just, all the different multi-centre sites are just currently getting ethics, and we will send this survey out to patients during our practice prevalence audit, which is what we're about to do. But it hasn't been prospectively validated in adult patients and carers of adult patients. And I think this is important. This is obviously important with the way that we've designed the survey, is that you can ask the question in the same way, whether somebody's an adult, a parent, a carer of a parent, with just some slight wording differences. And when I presented it at Vienna, I said, is anybody interested? Let me know, because we'd be very interested to have you validate this survey in adults and adult carers, and particularly the burden on adult carers. There was a lot in the HITH conference about burden on adult carers, which we ask parents about burden of care, but they never really say it's a problem in the home. But I think that's because they are all already looking after their children, so it doesn't really make that much difference to look after their children if they're unwell. And in some ways it's easier than having to navigate looking after them in hospital, whereas a lot of adults are not used to having to look after their adult loved one in the home, and so burden of care for them might be substantially different. So after I put out my interested question, we then had people from all of these different places say, yes, thank you, we're very interested, including just down the road, CEOC at Royal Melbourne. But likewise, if anybody's interested, we'd be very happy to have anybody involved in the prospective validation in adults. So finally, I'd just like to acknowledge all the people involved. Elise, of course, who did all the work. Leila Ibrahim is my longtime collaborator in HITH, who actually had the idea when we initially said we were going to do patient surveys as part of the FERN study. She said, what we should do? We should validate the survey. the broader HITH clinician group and parent group and staff and all the families who took the time to fill in the survey. That QR code is of either some interest or no interest. It's a QR code to all of the research that we've published so far. I put it there for the people in Vienna, but anybody else is of course welcome to read the research, because it's then obviously all the papers are free. And although I'm a paediatrician, a paediatric infectious diseases physician, I think a lot of the things that we do and a lot of the ways that we think about things in paediatric HITH is exactly the same as the ways that people are thinking about in adult HITH. And finally, I leave you with this thought.
That's exactly what it says on the tin.
And that's the end. Thank you.
Thank you very much, Penelope. Fantastic presentation. So we just have some questions in the chat, which we'll go to after Sarah's presentation. So Sarah, lead the way.
All right, hopefully you can see that, and I'll just put it in slideshow. Hopefully, is that in slideshow for you or not?
Not yet.
Not yet.
It is now.
All right, perfect. So for those of you who don't know me, I'm Sarah, and I'm the medical lead for Monash Children's at Home, which delivers paediatric hospital in the home for Monash Health in Melbourne. And it's hard to follow Penelope because she is A, much more experienced in research than me and much more organised, and B, quite a lot further along always in what she's doing than I am. But anyway, you live and learn, and all of you can help me on this journey. So I'm going to talk about care complexity scoring in HITH, for which we have started developing a score called the CCAT score. And we're now up to version 3, but I'm sure there'll be many other versions to come. So I have used some of the slides from the initial presentation on this 2 years ago at the HITH Society conference. So anything that is amusing in that talk is a repeat. So I already apologise for that. And my jokes are not as good as Penelope's, so that's even worse. All right, so if I can get the slide to move along, that will be helpful. Why measure care delivery complexity in HITH? So firstly, care provision in the home, we all know, has many additional factors to consider compared to care delivery on site in the hospital. And many of these factors are common to all hospital in the home or home care services and impact the way that we can provide HITH care because they consume resources. It's quite difficult to express this in a consistent way to people who aren't familiar with HITH logistics. And when we looked for a scoring system that someone else might have made for this purpose, we couldn't find one with a literature search. So we thought we would try and make one up. Now, this talk is very dry, and so because it's very dry, as with the first talk 2 years ago, I have used illustrations generated by AI as a metaphor for how it is hard to explain something that people think they know. So people think they know what HITH is and what's difficult about delivering care in the home, but they don't really understand unless they work in the space, particularly our executives. And so I asked AI to draw me some nurse cats, and throughout the talk there are various iterations of what AI thinks a nurse cat is. Now they all look fine on the surface, but if you look more closely at these, you can see that there are problems with what AI has generated. So in this one, these guys are sharing an arm in the left-hand photo. In the middle photo, there are disembodied arms, torsos. There's a big problem with these cats who are quite dysmorphic down here. This cat seems to have a human arm, so significant problems with what AI generated there. And over here, there's a random decision by AI about how much cat and how much nurse to put in each figure. So how should we measure HITH care delivery complexity? So my goals are that this would be a score that was simple to explain and simple to implement for our staff, and that hopefully it was broadly applicable. What have we done so far? Well, we first brainstormed a scoring system within our unit using our doctors, nurses and allied health, and then we tweaked it almost immediately, and then we reviewed its feasibility. And then we tested its concordance, which was last year's poster at the HITH Society conference, which showed some room for improvement. And now we have revised it again to be version 3. And we did that now in conjunction with the Monash Health Adult HITH team in order to make it a more broadly inclusive questionnaire and hopefully to deal with some of the concordance problems in version 2. So this is the initial version. So this is version 1. The broad categories remain the same across to version 3, but a few things have changed. So between version 1 and version 2, we added an extra score in here so that you had a little bit more delineation between moderate comorbidities and complex comorbidities. And in version 3, we've changed it from travel time to travel distance, and we've changed the way that we do the 4th category of social and psychosocial complexity. So just so you see what happened with version 2, and for those of you who don't understand statistics very well, which includes me most of the time, the Cohen's kappa values that our lovely Monash Uni statistician generated for us indicate whether there is good agreement between scorers, fair, moderate, substantial or strong agreement. And you can see based on the blurb below that actually the only place that we had even moderate agreement was travel time, and hence why the score has been revised again. And you can see this in a more graphical representation here. Sorry about the Met calls, I'm in the hospital, if you can hear those. So you can see this in a more graphical version here, and really the things that were the most objective to score, such as travel time, were the best, and the things that were the least objective, like psychosocial complexity, were the worst. And so overall, the concordance wasn't anywhere near where I would like it to be. So this is version 3. Now, obviously, you can't all see and read through this because there's too many things on this slide, but I thought I would show you the whole thing all in one go. So let's go through the categories one at a time. So the first category is for comorbidities and medical complexity, and that is scored 0, 1 or 2, depending on how complex your comorbidities are. So the third column includes an escalation of a relatively common, or less common now, problem in the hospital and the home, and how that might score a 0, 1 or a 2 based on additional complexities. And then there are some examples in moderate and complex complexities to try and help people decide whether their comorbidities in their patient are moderate or complex. Then we have the second C and the A, which stand for care delivery time and administrative tasks. So that's the time that's actually taken for the visit intervention done by HITH, and the administrative tasks are the additional things that our clinicians spend time doing: dropping off bloods, chasing bloods, liaising with the treating team, writing notes, etc. It's basically scored on time, with the exception that if you have 2 clinicians involved on the same in the same patient, then you automatically score 2, or if you're doing 2 visits a day, then you're automatically, or more visits, if your service does 3 visits a day, you're automatically going to score 3. So I've changed, as I said, the travel from time to distance. And realistically, this was because when I asked our 8 coordinators how they decided to score time when it wasn't as concordant as I would like, some of them scored it based on the absolute worst traffic that might happen on that day for that patient. Some of them scored it based on what time of day they thought the visit was going to happen for the patient. And some of them scored it based on the time of day they were filling out the score, as in when the patient was transferred from being an inpatient to being under our HITH bed card. And so it is just scored in brackets of distance. And then the last and most difficult category is social, which includes family, psychosocial and environmental complexities. So this is now a series of yes/no questions that are capped at a score of 3 and grouped together in similar difficulties that add complexities. So the first category is for communication difficulties, so poor English, illiterate or innumerate or other communication barriers. The second category for patients who are not independent and self-caring, which actually means that all of our younger paediatric patients will score 1 for this. And that is reflective, I think, that paediatric patients do in general take slightly longer to give care to than adult patients if they're not independent and self-caring. Then non or poorly compliant patients score 1 if they live in a setting that's going to require a little bit more difficulty to access and also more people to communicate with. So residential care, supported living, aged care, foster care or incarcerated, they score 1. If there's an AVO or other similar court orders in place, which makes the visiting more complex, they also score 1. And if they are on the NDIS as a sort of surrogate marker for disability, they score 1. So then we've just divided the totals into whether we think these are simple patients to deliver care to, moderate or complex. And so let's go through some examples so that you can see in practice how the score works. So these are examples taken from our own unit. So a patient that is probably common across adult and pediatric units is someone with leg cellulitis who's just coming for IV antibiotics. In this case, the patient lives 35 kilometres from the base, so there's not scoring anything for comorbidities. They get 1 for the time of delivering the care. They get 2 for the travel time, and they get nothing for social complexities. And then a 12-month-old with a buttock abscess that needs packing and dressing that lives very close to us, so nothing for comorbidities, 2 for the time that it takes to do the care and administrative tasks, 1 nothing for travel because they live so close, and 1 for being not independent and self-caring. Then moderate care delivery complexity. So our first example is a 6-year-old boy who came to hospital and home for ongoing diabetic education in the setting of a new diagnosis, poor diabetic control, family with non-English speaking background and poor health literacy, and also limited literacy and numeracy. As an added factor, mum had recently been in a car accident and was injured, and they were taking a long time to deliver interventions to, even on the ward. And they live 40 kilometres away, so they score, that boy is in HITH for his primary problem, so he doesn't score anything for comorbidities. His care and administration time scores a 2, travel time scores a 2, and the social category scores 1 for the communication difficulties and 1 because he's not independent and self-caring at 6. And then a 16-year-old who has chronic renal failure and is on home PD, who's got peritonitis, who we're delivering peritoneal antibiotics for, which takes 60 to 90 minutes and lives 35 kilometres away. So 1 for comorbidities, 2 for the care and administration time, 2 for travel, and nothing for psychosocial. And then our complex patients examples. So we have a child who is coming to hospital and home for parent craft and feeding issues that also has 2 allied health members involved in their hospital and home care. They are from a non-English speaking background, needing an interpreter. Their home's being renovated and they're staying in a crowded extended family setting. The child is suspected to have Down syndrome, which has not yet been confirmed, and they live 40 kilometres away. So that child gets 1 for comorbidities for the Down syndrome, 2 for the care and administration time, 2 for the travel time, and 2 for social, both for the interpreter and the non-independent and self-caring child. So, and then for the last example, we have a child who is 3 with Down syndrome on NDIS for global developmental delay. They have congenital heart disease and unfortunately post-surgery they've got Staph aureus bacteremia and endocarditis. They're of Aboriginal and Torres Strait Islander background. They live 35 kilometres away. Well, we're meeting them 35 kilometres away at our furthest secondary site, but they actually live 2 hours away, so they're actually driving to meet us there. The patient is uncooperative and we need to do midazolam when we're doing CVC dressing changes. They're also having Baxter antibiotics via the CVC. They need weekly bloods. They need insulflon replacement as we support the parent to deliver enoxaparin via the insulflon. So they score 2 for the comorbidities, 2 for care and administration time, 2 for the travel time, and 3 in psychosocial. So that's 1 for being not independent and self-caring, 1 for being on the NDIS, and 1 for being uncooperative. So hopefully that is relatively clear now we've gone through some examples. So what are we doing in our unit currently? Well, we're only scoring once per episode of HITH. Clearly, the score might be more accurate if we rescored them after the first visit or every day of the visit, but that would take more time than our coordinators currently have available, even though it only takes about 2 minutes to do the score for them. They are scored on the day of transfer to HITH because that's the day that the coordinators have had to go through most of that information anyway. We have 8 coordinators, so they're the people scoring, and they're all nurses. And we are not currently scoring our allied health only patients until we get the score more stable. And we are including the average patient complexity score for the month to our executive as part of our unit reporting. And what might it be useful for, this score? Well, I have a lot of hopes that if we get this score to be stable and replicable across a wide setting, that it could be useful for quite a lot of things. So in a day-to-day sense, it could be useful for balancing patient allocations fairly and efficiently between routes and staff members. It's good for predicting unit capacity for additional visits and patients, and potentially sourcing additional staff in a timely fashion if we realise that our demand is going to outstrip our capacity. I think it could be useful for advocating for funding to continue at the same remuneration amount as on-site hospital patients, which I'm sure we all agree should continue as HITH is funded currently in Australia. And that we should advocate ongoing for appropriate inclusion of patient groups under HITH rules if these are revised. And it would be useful, I think, to help us benchmark our services in a specific and relevant way that highlights the things that are common to our services rather than including all our differences, which often makes it very difficult to benchmark standard KPIs unit to unit because rural versus metro, the demographics of our patient population and the conditions we manage make our services actually same but different. So what other plans do I have for the future? So we're currently trying to track concordance internally with our version 3 score. After I'm happy with that, we would like to extend that to testing across multiple sites and making sure that it still stays stable. Of course, reviewing and revising the score as needed. And then once we have a score, we could then do some work on comparing it with outcomes, length of stay, DRG complexity, cost of care delivery, unit capacity per staffing versus the complexity score. So quite a lot of things that once it is working, I hope we can use it for. And so that's all for me, and I'll stop sharing. If I can find.
Thank you so much, Sarah. Fantastic presentation as well. Very, very relevant. Let me now just put back the background so we all know that the HITH conference is coming. So we do have some questions which we are going to go over. Let me just have a quick look because it's always a bit difficult. Technology. So there were some questions in regards to the Dropbox folder. So it is. I just
sorry about that. Yeah, I just realised that the QR code had been deactivated. I've reactivated the QR code, but now I can't. Obviously, we can't see it, and so now I got. Somebody said, could they put the link in? So I'll try doing that.
Which I put it in. So
okay.
Everyone, if they do really do want to go to it, it's just there. So let's start with the first question, which was the Victoria Health Experience Survey does send out surveys and has a report for home and community care program for young people. Some questions do not relate specifically to inpatient care with HITH. Have you discussed or plan to discuss with the VHES about making your survey standardized?
So the answer to that is that I wasn't aware of the Victoria Healthcare Experience Survey, which I think says something about the fact that we just clearly don't use it and don't use it in HITH. And I don't know of other units at the Children's Hospital using it. So I think that would be helpful. I mean, I'm sure there are, but nobody talks about it. So I actually don't know what people's experience with that is. I think obviously they would want to standardize their survey against ours rather than us standardizing our survey against theirs. But I think that it'd be useful to have a look at that, certainly, and see whether the questions are similar and are asked in a similar way, because it's always useful to ask questions in a similar way. The way that we've asked the questions is relatively standardized for the way that healthcare questions are asked. That was part of our content process right at the beginning. So I think we'll certainly have a look at that. I think that's a useful thing to look at, because you're right, we do want to ask the same things in the same way if we're trying to benchmark across services. Now, I'm not necessarily looking to benchmark against VHES, but if people are looking to benchmark the two, it'd be useful to have to make sure that they're similar. The questions about HITH, and I'm not quite sure, it says do not relate specifically to inpatient care with HITH, and I don't know whether that means some of them do relate specifically and therefore some of them do not. I'm not quite sure if Matthew can answer that. But yeah, that's I think that would be a useful thing to look at.
Thank you. The next one was from Felice, which was answered your presentation, which was, would the questions translate well into adult HITH space, or would require review and retesting? So I guess for those who are interested, is it retesting?
Yeah, so what the thing that I would say about that is that I think there really isn't much sort of from the sort of content point of view from the literature, but I definitely think that it would be useful to send the version that we've got to do the face validity testing. I think that's really important, and I think doing that with adults in the first instance, rather than just sending it out to 100 adults and going, what do you think? I think doing some face validity testing, particularly around, are we asking the questions in the right way about adult carers? So when we do that, which hopefully will be in the once I've done my 2 weeks of infectious diseases ward service, which start today, that's my next cab off the ranks, is to contact the people who've said that they're interested, and as I said, likewise, if any of the people listening here are interested, and say, would you like to sort of have this version that we've developed for adults, because it's basically the same, apart it says you instead of your child, and say, you know, are there other questions we should be asking you? Because that's what we did with the pediatric families. At the bottom there were, what other questions should we be asking you? Are these the right questions? So I think that it certainly would require review and retesting, and that's what the validation is. And I think just I might as well go on to the other two questions that specifically asked around what else could we do, and one is that any plans to translate surveys for called families. So I think that's a really good question, and because we have patients from Barcelona, researchers or clinicians from Barcelona and from Belgium, we're already planning to translate into other languages, and therefore I think translating it into other languages specifically for called families will be a good idea. So I think the slight problem with that is that all called families in different areas have different first languages, and so we know what our demographic is and what our top 5 other languages are at the Royal Children's Hospital, but that doesn't mean that's the same you know, in the Northern Territory or in Western Australia or Sydney or even at Monash. It's just different to different places. I do think with the massive leaps forward in AI, it would be relatively straightforward to translate into other languages, and at least have somebody who speaks those other languages as a primary language to look over it and make sure it says the same thing. So that's the next plan after the current plan of doing it in adults. And the other question, also somebody asked me the other day, one of my research team said, what about asking younger children? I think that's a great question. I think that's done too infrequently, and we would have to change the questions a little bit, but yeah, I think that's a great idea, Andrew, and definitely that would be another next step.
Fantastic. So that's a great segue to the AI. So Sarah, this question is for you. Have you considered an AI approach to pulling the complexity data set?
Well, the answer to that is no, mostly because I don't really understand AI enough, and also Monash Health currently won't let us use AI for anything that is clinically related. We are only allowed to use it for non-clinical internal meetings, and so that is the current limitation that we have at Monash Health. So I'm not allowed to, and I also don't understand how I would do it. So I would need to work on that in all the spare time I have.
Thank you, Sarah. And sounds like there is also a collaborator from Perth Children's Hospital, hopefully coming your way. The next question for you, Sarah, is I want to ask, when you switched out the travel time to travel distance, you removed the option for multi-visit patients. Is there a method within version 3 for capturing that?
Yeah, so I think this is sort of slightly non-intuitive now that you've brought it up, but multi-visit patients are actually captured in care delivery time as 2 visits, because it also captures using a second clinician. So it's in that category, not in the distance time category, because obviously it can't be in both. So it's still there, it's just not in the category. And it was in that category in version 1 as well. It's just maybe not intuitive.
Yes, Penelope.
So I have a question for Sarah, which I think we've talked about before, Sarah, but I'm sort of interested to ask you again. So one of the things in the current version of the complexity score is how long the intervention takes, and we do it slightly differently at the Children's Hospital. Is we measure complexity in all the ways that you've discussed, but come up with a sort of a solution which is a sort of endpoint, which is how long the visit takes, because all of those things get incorporated into that. And I'm interested, because you've got it as part of it, you obviously can't use that as the thing. And I sort of hear, it's very interesting, all of the things that you said this could be used for. On a day-to-day basis, does it help with allocating resource, or is it really in a slightly longer term fashion? Because that's I suppose that's what we're using it for, is to allocate a time resource, and that means that the nurse or allied health staff who are going to visit that patient need, like, 2 hours, for example, and therefore wouldn't be able to visit another patient. Therefore, we need another resource to visit another patient. But that's I wonder if you're doing anything on like a day-to-day basis with the score.
So the nurses do the score, so they all know the score at the time that they put the patient on. And to be honest, looking at the score currently, most of our patients end up in moderate. So, and I think that the ones that end up in simple or complex actually are fairly evident without scoring them in terms of from our nursing coordinator's point of view, because which might differ if we move to our admin allocating visits. I think it would be more useful for them because they don't have that background knowledge, and that's obviously an efficiency that we could move to in our unit. But at the moment, I don't think they use it. They just do it for me because they're nice. So I agree. It would be nice to have a way of confirming whether that really reflects complexity. And I think the question I have for everyone online is, I mean, we've arbitrarily just decided that 0 to 3 is simple and 4 to 6 is moderate and 7+ is complex. It'll be interesting to know whether people think that a certain proportion of patients should be falling in simple, moderate or complex, or whether that is going to be very difficult to ascertain because our services are all quite different. Because obviously you're going to score a lot less for all of your travel times if your catchment area is very small because there's another HITH service very close to you, and you're going to score a lot more for sort of medical complexity and interventions if you're doing more complex interventions at home. So I'm not sure that I could work out myself whether there should be a proportion that should fall in simple, moderate and complex, but I'd be interested to see what other people think.
Thank you, Sarah. It sounds like there's collaborators left, right, and center. This time is from the Alfred and helping with AI. So unless there's any more questions in the chat, we'll just touch on one thing, which is going to be an anecdotal, personal anecdotal, which is from James saying how he does encounter many patients which want to actually see the same nurse, and actually they're requesting irregular or specific nurses. And I can tell you that from my great auntie who was a midwife under HITH, twice. The first time she loved it, the second time she hated it. When I asked her why, the answer was, oh, the first time it was the same doctor who kept on seeing me. The second time I saw all these different doctors. How can they know what's going on with me? So it's always funny thinking about the patient. And while we do believe that we are providing the great care, it's quite nice bringing the patient back into the equation. So thank you so much, everyone. I look forward to seeing you in person at the conference. So please sign on. If you're not a member yet, as you can see, you have the QR code. And thank you so much, everyone.